get panel number 2 up here? Piroze Davierwala, Denis Bouchard, and Michael Chu. The topic is residual and recurrent MR.
Okay, so now we're going to move right into this one. This is obviously much more simple than the first one. So let's look at see if we can get through this. We're going to try and stay on time, so we may only have time for one at the end. Here's a 24-year-old patient that's had an A3P3 edge-to-edge repair, no mitral valvuloplasty because she has a small annulus, and they thought they had a good saline test. She had an effusion, had tamponade, had to have that drained. Went home, sort of mild to moderate MR, heard a murmur a month later. Now she comes with mild symptoms. Here's her echo, transthoracic. Any comments from our panel? What do you guys think? It's not the most rewarding of transthoracic echoes a month out, is it?
Well, there's some MR. It's just hard to quantitate how much MR there is, but.
Well, it looks like a lot on the parasternal long axis. The thing is, this is inadequate. Like, the patient should never have left the operating room. This is not patient didn't get an annuloplasty. All of the principles of mitral repair were foregone in this case.
Yes, it was. That we agree with. But we're talking about recurrent MR. So that's what we're talking about. Yeah, that's the reference center discussion. But this is the next discussion, which is what do we do? And of course, you can't really make any decisions based on this echo. You do get the sense again that you've got a wall-hugging jet. But this came with her. I organized that echo. That was done in our echo lab. But she actually had this in her back pocket, which was her echo from the outside hospital. What do you guys think of that? That's a little more definitive, at least in terms of degree of regurgitation.
Yeah.
So severe eccentric MR, very small ventricle. I mean, look at these ventricular dimensions, 2.5 in LA at 2. EF 66, very low risk, obviously. Thoughts?
Absolutely not. She's a young woman, and she was supposed to have a successfully repaired valve to restore life expectancy and to treat her symptoms. And now she has severe MR. This is completely inadequate, and I don't think active surveillance is reasonable at all. If it was borderline, then maybe you could consider a stress echo, but I would strongly suggest return to the OR. The other thing about the echo is that seeing the residual prolapse that's there is reassuring. It's reassuring because, it suggests that there's a high likelihood for re-repair of the valve. What I worry about is in cases when you have someone that's been repaired and, you go through the OR note and there was, a very complex sort of reconstruction, but you look at the echo and there's not enough leaflet material left when you have restriction and things like that. And that's when I get concerned about the ability or inability to re-repair the valve. When I see lots of residual prolapse where segments that were uncorrected are in place, that suggests a high likelihood for re-repair, and I would take that patient in the operating room immediately.
Yeah, you almost start at new, right? You've got a prolapse that has not been corrected. You've got no ring, so it's carte blanche.
I agree with that. It's pretty much would be like a primary operation again.
Yeah, I mean, any just concerns, thoughts, timing? When do you guys do this stuff? She's 3 or 4 weeks out now. So do you wait 3 months? Do you just go ahead? Do you check their hematocrit? Any thoughts about any of that stuff?
It would also be important to know from her whether she wants to start a family, and you wouldn't want to get pregnant with this kind of valve.
Yeah, she's not very symptomatic. She could be approached through the right chest if ever we were concerned about adhesions or if the first surgery was a stenotomy. And she's not very symptomatic, so maybe she started off surgery. So I would address with her whether she wants to have it fixed because she was in the mindset of having a good mitral valve repair, or she wants to gain some times. And
Yeah, we used to sort of have this, Joe, you want to say something?
I was just gonna say, she had an effusion with tamponade. Did she have any end organ injury, anything bad happen?
No, I don't think so.
Okay.
But, you know, these are the sort of, we used to sort of always back off on patients, like, oh, well, you know, it's like the worst time to do things. We typically don't think that way anymore. We usually make the decisions independent of the reentry or risk, or whether it's front, side, whatever. So I agree with you with, if the MR is that severe, typically, again, we probably do need to, there's just all different grades of severe, just like all posterior leaflet prolapse, not posterior leaflet prolapse. That's very severe. Here's the echo we did, just to get our views, which is a little more clear, I think. Yeah, sorry, Jabreen.
Technical MR, residual MR, is more or less malignant for two reasons. First one, we compromise, if we wait longer, we have the risk to compromise the quality of the tissue. And the second, in the majority of patients, we have somehow hemolysis. And so I don't know if you had, if you check for the hemolysis in those patients, because it's really very frequent when we have mainly early recurrence of MR.
So what you guys, could you understand that? I was having trouble hearing. Can you just say that again, Jabreen, real quick?
I mean, we consider the technical residual MR as a malignant one because we may compromise the quality of the tissue, making the redo repair difficult. And the second, the majority of those patients may have somehow hemolysis.
Yeah. Yeah, they can have hemolysis, and this is another issue. That's why I wanted to ask you guys about the echo. So, yeah, it looks like the edge to edge is probably intact, but the valve is obviously not going to work. So we'll go back to that story again. Is he going to get a repair? Is it resection, non-resection, add some more edge to edge, do a ring? How would you guys do that?
I find with the re-repairs, I don't have my plan as firmly in place until I see the valve. You know, primary repair, the echo tells me exactly what I'm going to do, but I really want to see what this valve looks like. And yeah, we want to re-repair it.
What was done at the original operation?
An edge, just reading the eye note, an edge to edge repair, and then no annuloplasty because the annulus wasn't dilated, and
On the echo, it looked quite bulky on the transvascular, whatever was done. So, you know, I would agree that I think you need to be able to take down whatever was done before and then re-go through your algorithm, whichever it is, to re-repair it.
And I agree with Mark. I would come with the plan to re-repair the valve, but I would not come with a fix. Am I gonna do leaflet resections or just add cords? That's something that I would sort of see on the spot once you have undone the Alfieri.
You might need both the techniques actually, because it's most likely if the Alfieri is ripped off, then the valve is already torn. We can always do a partial resection, and if required, put in cords to correct the prolapse if there is a residual prolapse.
I just wanted to address Jabreen's point earlier. I do think hemolysis is an important thing to look for early on, because the scenario is commonly that you get a very eccentric residual jet, and it hits the ring that's in there. In this case, there was no ring, but it hits the ring that's not pseudoendothelialized yet. And so these patients will oftentimes come with significant hemolysis, which you might not recognize unless they tell you they have dark urine or other things. But I think it's a very good point.
yeah, you know, my argument's sort of like if you had an annuloplasty and you did something, and then they come back and they have moderate MR, they're very upset. But I try and sort of walk them off the cliff because those patients that have an annuloplasty, you know, actually that's stabilized some of the mechanism of progression of MR, and then oftentimes they'll wait a year or two and they'll end up having something. But most of them just come because they're all coming to us for, you know, most of them come for second opinions and they're all mad and they just want to get fixed now and blah, I should have come here, blah, blah, blah. And I walk them off the cliff and tell them, you know, for many people, the annuloplasty alone plus moderate MR will stay moderate for a long time. So we almost never just rush back in and do things if you have an annuloplasty. This is a little bit different because it's obviously severe and it was an inadequate repair. It goes back to our old algorithm Monty wrote about inadequate repair. This is inadequate first attempt, so we don't really have a lot of the little cleft got frozen, a cord got restricted or something like that may stop and do that. This was A3 prolapse originally, probably not going to be resection. Let's look at it though, because this one's what's more interesting. You can see how small the valve is, tiny posterior leaflet. The edge to edge is intact. This is one kind of edge to edge you can take apart. The clips get harder. They grab all the cords underneath it. As I said, always look at the other side as well. See these restricted cords in P3? I think sometimes you start with you get anterior leaflet prolapse because you don't have the coaptation posteriorly, put stress on cords. So there we cut restricted cords, remodeled the posterior leaflet first, chordal transfer, then Gore-Tex. And small and true-sized annuloplasty, very small annuloplasty. So I do think you can, just because the annulus is small, you can follow the principles. And I think this case really reinforces in every circumstance, annular stabilization is part of getting a durable repair. Okay, here's the second patient. She's 82. She had a robotic operation 2 years ago. I want you to look at what she had done robotically. Unblock, let's see, we got to get a slide up, guys, somewhere on one of these monitors. Whoops, go back or go forward. Okay, next. Got to keep advancing here. Slow down now. Next. Next. Okay, don't touch. Robotic mitral valve repair 2 years ago. Robotically, unblocked MAC resection, P1, P2, P3, bovine patch, groove atrioplasty with resuspension of the leaflet, septal myomectomy, and 32 future band. That's a lot of robotic surgery. That's a different topic, Mark. Isn't that a mouthful robotically?
I can't do any of this stuff robotically.
Yeah, I can barely do that in an open fashion, but at any rate, that's the operation that she had. And here, she's 82. Next slide. I'll let you do that. Guys, we got to advance the slide. Oh boy. They're trying to do this.
I think you make a great point. This is a really big operation, and you've got, in my opinion, to have a sternotomy to attempt all this stuff.
Mark, I mean, the other issue is she was 80 when she had that done. I am sorry, I will not drink that Kool-Aid. When you're 80 and we got to do robotics because we got to fit a patient to our robotic series. This is, sorry, I don't get it. When you're 80, you need quick, efficient surgery, not fancy stuff. Okay, here's her echo, sorry. Here we are. That's transthoracic, and let's just advance for the sake of time. Here's the transesophageal. What do you guys think?
How's the patient clinically at the present?
Okay, next slide. So she's got a prolapse. Her ejection fraction is 48. There's her STS, 3.4 and 6. Of course, now that she's aware of all this, now she's complaining a lot, I don't feel good, I'm sleeping with 2 pillows, I'm not happy, I don't feel good, I really want to get this fixed again. And she goes, by the way, to see the surgeon that operated her on the first time, and he's already planted the seed, I'm going to make this better. Robotically, a second time. I'm not making that up. But she's getting different opinions now. So she really wants to do that, and she's thinking maybe robotics is not the right thing. Transcatheter palliative option, what do you guys think? Any ideas? She's got a prolapse, she's got an incomplete ring.
Yeah, I don't think that transcatheter option is necessarily a bad choice for her.
What option? She's got a steel rigid ring that's size 32.
How big
in
was the
there.
ring?
It's
Huh?
How big was it?
32. Yeah.
32.
And the drawback of the transcatheter repair is that if it doesn't work, that's going to be a valve that's going to be replaced, for sure. They're hard to fix. And,
Yeah,
and
no,
maybe the
less
ring is
elective
too small
setting.
to start with, but that should be addressed in terms of valvular area.
Yeah, I guess the issue is what's the residual valve area, right? So if the valve area is over 4 centimeters, then maybe it might be an option. It looks like, there's a broad P2 prolapse that's left there. And that was surprising. There's a whole jumble of things that they did, but didn't address the P2. So, if she's quite symptomatic, I think, bring her back. And, if it's a very straightforward sort of P2 resection or cords, then I think it seems reasonable. But again, an 82-year-old that you're bringing back for a repeat surgery that just happened, I think you should also have a low threshold to consider replacement.
Absolutely. That's for sure. This is never about repair or replacement in an 82-year-old in a re-op setting. This is about a competent AV valve. No more, you can't do experiments. I mentioned this robotic thoracotomy or sternotomy. Is anyone electively doing repeat thoracotomy, or, I'm just trying to learn, or robotic second time if you've done that 2 years ago in an 82-year-old,
No, I'm not.
or anybody?
I think Doug Murphy, from time to time, will. He's got a paper out, I think, in Innovations about that.
That's so repeat thoracotomy for, yeah.
Yeah.
Again, I think you can fit any patient to any paper you want to write, but I do think you're introducing some other complexities then.
But I do want to stress that the failure here wasn't the robot. The failure here was inadequate repair. So, it's just from the get-go, right? It was inadequate repair. Whether it's robotic, sternotomy, minimally invasive, endoscopic, doesn't matter.
Well, Michael, we can say that, but I will tell you again, if I keep adding complex things to more complex things, then I tend to get more inadequate things after I'm done. Meaning, trying to do all those things robotically. Let's all agree, every single paper in the world and every robotic expert Mark will agree that it takes more attention. You can make them, just like we watched last night, you can win the NBA playoff game with 3-pointers or layups. If it's my life on the line, I'll take the layup. It's a little bit higher choice. So robotics is a little bit more advanced. So if you do robotic approaches and then you do more advanced pathology, you're more likely, the combination's more likely to maybe lead to an inadequate repair.
It's a very simple
You
question.
agree with that, Michael?
I think a circumferential MAC is close to an absolute contraindication for a non-sternotomy approach. At least that's what I think.
Here's what she had.
So you still prolapse.
So there's the ring, residual prolapse. Michael, to your point, the posterior leaflet, I think, probably needs to be dealt with, regardless of what you want to do, and the first operation can probably be done a little bit better. Yeah, personally, you can see that's a leaflet to leaflet rotation. We don't really want to go into this patch that's below the ventricle. And so we basically rotated the leaflet similar to what Pat was talking about, but we did it leaflet to leaflet, not into the annulus. And there's a ring with that. I mean, the valve repair itself was pretty straightforward. the decisions around it and trying to decide whether to do it or not is really where the discussion is. But I think that.
Can I ask a question of the
Yeah.
panel? On these re-ops, I am always tempted to leave the ring or band in place. But then inevitably when I get it, because I say to myself, okay, it's just gonna be a simple posterior resection. But then when I get in there, I always end up taking it out because I just feel that I'm unable to adequately make my assessment to plan for the reconstruction. How did the rest of the panel feel about that?
I almost always take it out. I like to start over if possible, and also the angular sutures you place give you better exposure, as David did in all of his videos.
Yeah, I think the other thing is I've seen, I'm curious if you guys appreciate that. It seems like almost invariably, even when we do our own re-ops, we're putting in a smaller ring the second time.
Yeah.
And I think one of the mechanisms of that, and that's one of the reasons that I love the concept Pat was reinforcing about depth of closure, gives you more leeway, less residual, because leaflets shrink. I think all this manipulation in complex leaflets, some of them react by fibrosing a little bit and getting a little bit smaller. And I do think almost invariably, when we measure again, it just feels like we want to, the rings are going to be smaller, which is also one of the reasons sometimes patient gets replacement, because if you start out with 28, now we're talking about 26 or 24, I'm less inclined to do that in the reoperative setting chronically versus a biological valve, particularly if you're older.
I don't always take out all that material, though. Take out the metal part, because if you always start by taking out the entire ring, all the fibrous material, you always have that deep groove, and you have to work within that groove. Sometimes it's nice to take the metal part of the ring out first and then figure out, does that give you enough of the exposure, and can you mount your sutures inside of that fibrous material?
Yeah, Joe, that's such an important point. If you want to do mitral valve re-repair and you have rings that have metal in them, if you take the metal out first, not only do sometimes you don't have to take everything out, but more importantly, it's much more likely to not damage the hinge point of the leaflet and the commissural areas when you're trying to cut underneath the ring. And then you detach, create a perforation near a commissure. Now you're closing a commissure. So it really is better to take out the piece of metal first if it's a metal ring. The Cosgrove band's the hardest one to take out. They were designed for ingrowth.
They calcify their eye.
Yeah, they're very tough to take out. Okay, we better move on. We've just got 10 minutes. We're going to show one last case. We're going to skip the second one. Thanks, guys.